Thank you, Michael. So for a different perspective from Middle Europa, we turn to Sibylle Loibl, chair of the GBG, who will take the con side of the argument.
Thank you, Hal, and thank you, Michael, for giving a historical tour through Vienna, but now we want to see the facts. So let's start from another perspective. I think we need chemotherapy, and I show you why we need that. So this is my conflict. So you have seen the chemotherapy effect in premenopausal women, and not all of the data you have just seen were the contra-argument. There were a lot of data supporting that chemotherapy has a value in premenopausal patients. And the data from the MINDEC trial here shown on the left and on the right side from the RxPONDER trial in intermediate risk patients saw a hazard ratio of 0.54 for the MINDEC premenopausal women with node-positive disease in favor of adding chemotherapy on top of some endocrine treatment, with the use of a GnRH analog being higher in the MINDEC trial than in the RxPONDER trial, where we have a hazard ratio of 0.66 for the updated analysis we just saw yesterday for the distant disease-free survival. And then depending on the absolute risk an individual patient has, of course, the absolute benefit from chemotherapy varies. And I want to remind you, you have heard about the age. Only 2% of the patients in the RxPONDER trial were below the age of 40 years. So the recurrence score and the MammaPrint do not help to select which premenopausal patients can really forego chemotherapy. And because cancer in young women and in very young women is biologically different and probably therefore more sensitive to chemotherapy. The importance of age differs by the biological subtypes. I'm arguing in favor of that, and this is data from Hatem Asim a couple of years ago already, and showing clearly on the right side that in luminal breast cancer, age matters. Patients with being of young age have a significant worse prognosis in luminal A and luminal B breast cancer, but it does not play a role in the patients with triple-negative breast cancer. And this is true today. We looked in our registry and looked at the data for women below the age of 40 years. And below the age of 40 years, you have even a further split for those being young and those being very young, a split only, again, in the luminal breast cancer patients. There is no difference in the triple-negative patients, and there is no difference in the HER2-positive breast cancer patients. So biology matters, and biology in young women is different. We need to keep that in mind. And I want to show you that because the biology is different, chemotherapy works, and this is the data from neoadjuvant chemotherapy, and because we measure pathological complete response, which is a short-term effect, so the ovarian function suppression effect cannot kick in here. You see a clear correlation in favor of younger women having a higher PCR rate, and this is a clear linear correlation. The younger the women, the higher the pathological complete response rate. And looking at the forest plot, again, you see this is only true for our luminal breast cancer patients. It's not true for the triple-negative breast cancer patient, because in triple-negative breast cancer, age doesn't play a role, and therefore the PCR rate is high anyway in older and in younger women. And this translated into a benefit in favor of pathological complete response achieved only in the young luminal breast cancer patients. The top are the young patients with a PCR, and the bottom are the young patients without a PCR, whereas in the other age groups in luminal breast cancer, PCR is not so much difference. Whereas in triple-negative breast cancer, there's a clear split. PCR on one side, non-PCR on the other side. So chemotherapy works in young breast cancer patients. Why can we see that the biology is different? And this slide was given in courtesy to me by Lars Puster, and he elegantly analyzed gene expression data from various cohorts and found out that in overall young women had higher immune gene expression which likely makes them more chemotherapy sensitive, and lower ER-associated genes that could make them less endocrine sensitive. And you see this here on the left, the younger patients with more higher signature and lower ER signature, and here the older patients. And this is under review at JNCI, and I hope this will be accepted soon. And please read it, because it gives you an insight that the biology of the tumors in young women is different, and therefore chemotherapy is an option and chemotherapy is needed. So adding ovarian function suppression on top of chemotherapy works, and you have heard very elegantly that chemotherapy induces amenorrhea, and I think we can agree on that fact, that chemotherapy induces amenorrhea. If that's all, and if that is the only thing patients need, we can see here. This was a study from our Asian colleagues, and patients who became premenopausal or started having a menstruation again after chemotherapy-induced amenorrhea were randomized to then start with a GnRH analog on top of tamoxifen. And you can see the majority of the women have only a temporary ovarian function suppression effect by chemotherapy, and they start menstruating around 6 to 7 months after they stopped chemotherapy. And you can see here that adding a GnRH on top of tamoxifen when the patient started menstruating again is helpful. And the ovarian function suppression is temporary and does not explain all the chemotherapy effect. And in fact, in SOFT, those patients were enrolled as well in the trial, those who regained menstruation function within 6 to 8 months after completing chemotherapy. These are the SOFT trial, and I want to show only the comparison with tamoxifen here, not the comparison with AI. If the chemotherapy effect would only be ovarian function suppression, then an additional ovarian function suppression agent wouldn't have an effect. Then the tamoxifen curve and the tamoxifen plus OFS curve would be so superimposable in this prior chemotherapy treatment cohort. So let's go back. I also digged out some of the old GABG studies. This is GABG 4. And you heard already that the studies were not ideal because they enrolled hormone receptor positive as well as hormone receptor negative patients in an endocrine related question here. And this is the subgroup of the hormone receptor positive patients. The patients received not only CMF but EC followed by CMF. And in another group, they added goserelin to that. And again, the addition of goserelin was better than just the chemotherapy effect alone. So both is needed, obviously, in hormone receptor positive patients being at high risk for receiving chemotherapy. And the IBCS G8 trial, so we looked at the same study groups but picked out different trials. This is the IBCS G8. Looking in pre- and perimenopausal women, looking at 6 cycles of CMF, 2 years of goserelin, or the combination of 6 cycles of CMF followed by 18 months of goserelin. And again, in those being younger than 40 and being hormone receptor positive, this is the clear curve of the combination therapy. And the GnRH and the CMF curve is below that. And you can see here in the step analysis that the separation of the curves kicks in until the beginning of the early 40s, and the amenorrhea curves also supports that the amenorrhea is temporary and the patients start the menstruating again. So, efficacy of chemotherapy. The early breast cancer trialists have done multiple analyses supporting this. And here the chemotherapy effect is about a 20% relative risk reduction. And this works in all patients, independent of age and independent of the hormone receptor status. You see here the forest plot clearly supporting the effect in older as well as in younger women. And why should chemotherapy work in older women when it's just ovarian function suppression? Taxane versus no taxane, again the same picture. Chemotherapy works in all age, and it works in hormone receptor positive, in younger and in older women. They use the cutoff of 55 here, but it supports the argument well. And then dose-dense chemotherapy. Why should dose-dense chemotherapy work if it's only ovarian function suppression and has no additional cytotoxic effect? Here you see the data. It works also in patients with low proliferating tumors, and it works again independent of age, and it works independent again of the hormone receptor status. So efficacy of chemotherapy depending on age, I have shown you that in some of those trials where they looked at the real young patients, they saw an age-dependent effect in favor of chemotherapy. So chemotherapy is needed on top of tamoxifen. And again here, another subgroup with a 50% risk reduction for the addition of chemotherapy. So chemotherapy-induced ovarian failure is obviously there, and we looked in prospective series across different chemotherapy regimen about the potency of the chemotherapy regimen to induce ovarian failure, measured not only by the amenorrhea and by history taking, but also by analyzing the serum levels. And we saw that in one of the standard regimens, paclitaxel, up to 20% of the patients did not have ovarian function suppression with chemotherapy, which was higher with a dose-dense regimen of 95%. And the restoration of menstruation or the restoration of premenopausal function is continuous, and the majority of patients regained a premenopausal function based on serum levels within 2 years, and this was 70%. So this is a temporary effect. Amenorrhea is supportive, is a prognostic factor, and the NSABP showed very elegantly in their data, irrespective of the hormone receptor status, whereas in our analysis based on the serum levels, we could only detect a prognostic factor for those patients who have a shutdown of the ovarian function for the patients with hormone receptor positive tumors. And I want to bring out some issues with GnRH analogs, which did not been mentioned by my elegant speaker before. The effectiveness of ovarian function suppression, the adherence, and the quality of life, which we have with a GnRH analog. So first of all, also the GnRH analog does not suppress the ovarian function to 100%. These are data from the SOFT trial, and they measured the serum levels of estradiol, and you can see that up to 20% of the patients, even after 6 months of treatment, did not have a complete shutdown of the ovarian function, which needs to be taken into account, because otherwise this results in gross undertreatment, especially if the patients are treated with an AI in addition to the GnRH analog. Adherence is lower in younger women. These are the data again from the SOFT trial. The blue curve is the patients younger than 35 years of age. They have a higher cessation of GnRH agonists, and they have a higher rate of moving to permanent ovarian ablation. And quality of life, in the end, tamoxifen versus ovarian function plus tamoxifen, you see here the patients with prior chemotherapy do not suffer so much from a GnRH analog than the patients who did not receive chemotherapy. And this was not only in the first 6 months, this was actually permanent, and we need to take that into account. Similar picture for the loss of sexual interest. So in summary, I strongly believe the biology is different in young women with hormone receptor positive HER2-negative breast cancer. It's a different disease. The PCR rate measured after neoadjuvant chemotherapy correlates with decreasing age, and this supports there is a direct effect of chemotherapy, and all the EPCTG analysis support a unique chemorrhea effect. Even high-dose chemotherapy works. Induction of amenorrhea is there, but it's not 100%, and amenorrhea is simply a prognostic factor, that's it. GnRH does not suppress the ovarian function to 100%, again 20% about don't have a complete shutdown of the ovarian function, And GnRH analogs improve outcome in premenopausal women, also in those treated with chemotherapy, but toxicity and compliance with ovarian function suppression is an issue. So, in conclusion, chemotherapy effect is there, and it is higher in young women with hormone receptor positive, HER2-negative breast cancer than in older women. Chemotherapy effect has clearly two components. There is a direct cytotoxic effect, which cannot be neglected, and there is an endocrine effect on the ovarian function suppression. I think both is needed in young premenopausal patients, and the decision on a GnRH analog is important and should be considered based on the risk of the patient, but independent of the chemotherapy. And with that, I would like to thank everybody who supported me, the people who gave ideas when we were sitting at the St. Gallen panel, and those who I could discuss my talk with, and I send Christmas and season's greetings from Frankfurt to around the world. Thank you.
I knew this was going to be good. Okay. Here's our chance for some live polling. For those of you in the audience, if you look at the screen and use the QR code with your camera function, you will be taken directly to the Slido website, and we're going to ask a couple of questions of all of you as my speakers refresh themselves momentarily. So take out your phones or go online. And are you getting this? Somebody nod in the audience that it's coming through. Okay, so you have this on your QR. If there's an old person in the audience like myself who has no idea how to do this, find a young person here and they can show you how to grab the image. Okay, so here's our first voting question. You're discussing adjuvant therapy with a premenopausal woman who has early stage breast cancer, ER positive and HER2 negative, and a lower risk genomic score. How much of the benefit of chemotherapy is due to chemotherapy as a cytotoxic drug versus how much is likely to be due to the ovarian suppression effects of chemotherapy? Your choices are, it's all due to chemo, it's mostly due to chemo, it's about 75% due to chemo, half and half, mostly due to ovarian function suppression, or nearly all due to ovarian function suppression. And we'll give it another few seconds here. People are still collecting votes. Great, we have nearly 500 votes in, so nobody thinks this is all because of cytotoxic chemotherapy. That's sort of a straw man here. Michael, it looks to me like about 2/3 say it is either mostly or all due to ovarian function suppression. What's your take on this?
Well, you know, we have a very smart audience. And, you know, they realized that Sibylle, in her marvelous talk, obviously included all the high-risk patients in her presentation. And for that reason, particularly when you ask about lower risk, or intermediate risk for the matter, then it's mostly about, I think we can come eventually to the conclusion that, you know, there will never be 100% in anything. And, you know, obviously when you face a patient with endocrine non-responsive disease, neither way of ovarian function suppression will work, and those are patients for chemotherapy. But the question is, we still have to identify how to find out appropriately.
Sibylle, what would your answer have been here? You obviously didn't say in your last slide that it was all chemotherapy. So how would you break out those differences?
I think both kicks in. I'm pretty convinced that we need the cytotoxic effect and we need the ovarian function suppression effect. And of course, there are patients with low risk who might not need chemotherapy. And some of the intermediate risk patients, they don't need chemotherapy too, I agree. But we were not speaking about high risk or low risk patients only. We were speaking about the general effect of chemotherapy. And I think there is a cytotoxic direct effect. Otherwise, we wouldn't see any difference in the PCR rates for younger women. And there is also an ovarian function suppression effect. And it depends very much on the individual risk of the patient if you decide to go for one or a combination of the two.
All right, let me do 2 case scenarios for our audience. So back to the audience response system here. I'm going to pose 2 cases for you. Here's the first one. A 43-year-old woman with a mammographically detected 1.4 centimeter intermediate grade ER-positive HER2-negative cancer, metastatic disease in 1 of 3 sentinel lymph nodes, and a recurrence score of 13. Would you offer tamoxifen alone, ovarian suppression plus tamoxifen, ovarian suppression plus an AI, chemotherapy plus tamoxifen, or chemotherapy, ovarian suppression, and an AI? We'll give you a moment to answer.
How old was she?
Yeah.
How old was the woman?
We see.
How old was
43.
43.
Sibylle was asking to clarify how old is the patient, and 43, so not extraordinarily young, but 43. Okay, it looks like we're settling out at around, well, the plurality is ovarian suppression and an AI. Still half the audience giving chemotherapy here, interestingly, with either tamoxifen or ovarian suppression and an AI. Michael, how would you vote in this case?
Well, you know, I decided between tamoxifen and ovarian function suppression plus tamoxifen. And what I see, the symptom for this result is that we have all these wonderful trials and we do all these multigenomic tests. And when it comes to the crunch question, we still fall back on nodes. And I used to have a Latin teacher who always said, one mistake is no mistake. So just because there is one positive lymph node, everything else in this patient, she's not particularly young, she has grade 2, which is as harmless as it gets. Harmless is the wrong word, as, let's say, good as it gets in that age group. And the recurrence score is low. And we have now repeatedly demonstrated Taylor X, responder, MIND-ACT, that with that type of risk, you're not benefiting from chemotherapy. Not even from ovarian function suppression via chemotherapy, because I would actually argue against that notion. And Sibylle has correctly said that ovarian function suppression is not always perfect. But are we really giving chemo just to supplement the ovarian function suppression? Let's just improve on the ovarian function suppression. That's what patients would say.
Sibylle, I'm looking at the numbers as they roll in, and we're talking, this is a global audience now of hundreds of the most interested breast cancer specialists and care providers and patient advocates and patients themselves in the world. It is exactly split 50-50 between those who would give chemotherapy with some endocrine treatment and those who would not. Where did you fall out on this case?
I think it's a very difficult decision just made on what we see here. I think that's why I asked for the age. Okay, the age is 43, and I would also look at the level of the hormone receptor positivity to help me guide, and I would look at the Ki-67 to make the decision easier to give chemotherapy or to not give chemotherapy. But I have to admit, in this case, I would not automatically give the patient chemotherapy.
You mentioned Ki-67. Obviously, that is included in the recurrence score, and because of other reasons of late, we've been thinking about Ki-67 a lot more. How likely is it, do you think, that a low recurrence score, low mammoprint would have a high Ki-67?
Oh, that's very unlikely.
Very unlikely. Yeah, that would be my experience as well. All right, let me ask one more question for the audience. This was designed, I confess, that was designed to be the low-risk question, so I'm really interested in here. This was the higher-risk question. Same patient age, same tumor description, but now 2 lymph nodes positive and a recurrence score up to 22. So we've shifted the needle on that. Let's just get a quick sense. And based on the early returns out of New Hampshire, the Americans will appreciate that joke. There's a little town in New Hampshire that votes at midnight on election day. So those are the early returns to come in. But Michael, based on the early returns here, nearly everyone is giving chemotherapy for 2 positive nodes with a recurrence score of 22.
Well, that's obviously a very tough case because you're pushing everything to very close to high risk. 2 out of 3, well, yes. I think, as Sibylle said, in such a case, I would figure in additional parameters, such like, if this patient had, which is unlikely at that recurrence score, perfect 100% both receptors, I still would believe that it's luminal disease. And whether the recurrence score of 22 is so much different from a recurrence score of 19 that it justifies to blow the hair away from these patients for 6 months, I'm not so sure. However, I will agree that in my own multidisciplinary tumor board, I would have had a hard time in arguing not giving chemo in 2 out of 3 lymph nodes.
Sibylle, let me go back to you, because I think you made the key point for the whole debate, truthfully, which is, if it's not just ovarian suppression, you have to imagine it's biology in younger or premenopausal women that determines the benefit of chemotherapy. And so my question is, where is that biology lay? You showed some very interesting data from Lajos, Pusztai, and others, but we've gotten used to the idea of thinking that with a recurrence score, with other gene expression profiling assays, we're accounting for the vast majority of biologic heterogeneity. Are we mistaken in that assumption? That is to say, can we not take confidence that a low recurrence score is truly associated with a good prognosis across populations, as Michael had shown, and in multiple patterns now we've seen, low recurrence score, less likely to have a PCR, better overall prognosis, more sensitive to endocrine therapy, same for all the gene expression profile assays. So where do we go to find that biology that signals where we need chemotherapy?
This is a very good question, because I think the gene expression profiles we are currently using in the as standard diagnostic tools, I think they don't capture the right biology for our premenopausal patients, because we have to keep in mind the tests were designed and validated in postmenopausal patients, and they were only retrospectively used in premenopausal patients, and probably these are not the ideal genes for the premenopausal patients, like immune genes are not captured in those tests. And I think we might need other tests, and we might think differently. We can measure the TILs. If the TILs are just enough, or we don't know, but this is a simple tool we could add. We need to look at the proliferation Ki67. I don't want to discuss the right cutoff. It's a continuous marker, like the hormone receptor status. We need to look at the progesterone level. We need to look at that continuously as well, and we should not look only to the hormone receptor positive versus negative. And I think if we take that together, we might come up closer to see the different biology of our young breast cancer patients.
I mean, to me, that really looms as the key issue, right? Because, if you look at the Joe Sperano data that Michael showed, it was very interesting that the benefit was really in those tilted towards the likelihood of chemotherapy-induced menopause in the low score range. Go.
I think I agree with Sibylle that, we need to identify what makes this claim on a molecular basis reality that the disease is different. But keep in mind, when you just look at the curves, and Sibylle has obviously, in making her point, selectively chosen some of them from the Oxford overview. I mean, this includes triple positive disease, all basal-like cancers. We have seen at this meeting, again, excellent data that some of the luminal breast cancers, they are still not endocrine responsive, just because we believe by immunohistochemistry. And when you assume that in those patients, chemotherapy will probably make a 30 to 40% absolute difference in terms of the benefit, and then you figure that into the overall 2.8% benefit in RxPONDER. I'm not sure that it is true for everybody who is young. These are the germline mutated patients, undetected in these trials. So I think the proper identification is a huge scientific task, but I would claim that there are patients at age 33 who have excellent responding endocrine responsive disease and who can be treated without chemo. You need to watch out for any indications of non-responsiveness. I found that pragmatic approach of pre-treating them before surgery while the staging is ongoing actually rather elegant, and I will try to implement this in my practice.
So we have a few minutes to go, and I want to get to audience questions. We'll go to the microphone first, and then we have some dozens of questions that have been posted online.
Thank you, Harold. Thank you too to Michael and to Sibylle for the wonderful debate. And I agree with Sibylle to one degree, which is that premenopausal women have got a slightly different disease. But I think there's an important point to make about GnRH analogues. I disagree completely with you that 20% do not get full suppression. They don't if they don't take the treatment. But we did the work on Gaserlin 20 years ago. You get full suppression, you get stimulation and full suppression of FSH, and you get slight upward drift at 6 months. But the estradiol level stays the same throughout. When you give them tamoxifen, it slightly depresses estradiol further. And if you give them an AI, it depresses it further. These women all get full suppression. And it's really important across the world that we don't think that GnRH analogues, 20% don't get suppression. Michael showed you in the ZEBRA trial that all those patients had amenorrhea for 2 years. And that again shows that. And finally, we took out the ovaries of the patients in the very first study after they'd had their GnRH analogue. Nobody else responded. They had full suppression. So I think that's a really important point. So my question comes really to the first statement you made when you said, if you give them chemotherapy and a little bit of endocrine therapy, Michael's point is if you give proper suppression, you don't get that additional value. You never really address that. Because in the PONDER trial, 33% of people, as he pointed out, was premenopausal, but only 15% roughly got ovarian suppression, and probably not full suppression because they weren't taking the drug by the looks of it. So you haven't really addressed the question of full suppression. What does chemotherapy add to that?
Sibylle, do you want to respond? There's a lot in there, but maybe just tackle a little bit of it.
Yeah, I mean, we can discuss later, I think. But I think full suppression, the cytotoxic effect is still there, even if you have a full ovarian function suppression, as you say. But I cited the soft data, and the soft data showed there is still in about up to 20% of the patients have a still higher than full suppression estradiol level. And of course, and if you take out the ovaries, then of course you have a full ovarian function suppression. I still think this is not always enough for the patients with a hormone receptor positive disease because of the biology, even if you might receive a more complete shutdown of the ovaries.
Let me move to sort of the lightning round portion here in our final minutes. You're allowed to answer these questions in 1 sentence or less, the rules, okay? So, is tamoxifen alone dead as a treatment for premenopausal node-positive breast cancer? Is there any woman who has those criteria who can be adequately treated with just tamoxifen based on the collective SOFT and TEXT and RxPONDER data?
Absolutely. Look at soft text. It identifies about, in my practice, that's about half of all patients. Lowest risk, no indication for increased risk, give tamoxifen only.
So,
yeah, patients with low risk, they can do with tamoxifen only. It's a risk-based scenario. If you are very clear that you don't want to give chemotherapy, it's not an intermediate risk patient. It has to be a low-risk patient, small tumor, node negative, and really high hormone receptor levels and low Ki67. I think this is a patient we can treat, even if it's premenopause, with tamoxifen alone.
if you're giving ovarian function suppression, how many years do you give it for? Answer in 1 word, please.
3 years.
3.
5 years,
5.
as long as the patient tolerates it. That's
How do you give an answer in 1 word to that question?
5. The correct answer here is 5.
I'm a woman, I get more words.
We have a question at the podium.
Hi, this is a global oncology perspective questions. In some countries, oncologists don't have access to recurrence score tests. And based on the RxPONDER trial, there are a lot of patients who undergo chemotherapy even when they don't need it. Do you think there are some clinical or pathology features where patients with node-positive tumors can forego chemotherapy in the sense of the trial?
One sentence?
You can have a couple
You know,
sentences here.
Excellent question, but ask it the other way around. Who is the node-positive patient who will need chemotherapy?
So presumably, we're looking at things like size, ER and PR expression, grade,
Those are, so you're stuck with the
non-genomic
pathology
profiling.
features.
Yeah. Sibylle, can we define those patients?
I think we can. We have, as I said, the ER level, the PR level, the Ki67. We can look at the TILs if you have them. These are easy to get measurements ready available, and I think I would use them on top of the individual age of the patient. I think a 30-year-old patient is different from a 43-year-old patient.
So let me just ask you to put on your future hats. When you show up for San Antonio 2029, we're using more, less, or the same amount of chemotherapy in younger women with ER-positive, node-positive breast cancer.
Young attendees in 29 will ask, what kind of treatment?
What does that mean?
What
Oh, you mean for chemotherapy?
Yeah.
Because we're not doing, it's an ancient history.
Yes.
You might as well be asking about, melphalan or something like that.
Exactly.
Sibylle?
Well, we have new treatments coming up with the CDK4/6 inhibitors. We have maybe SERDs coming up, which hope to be better than the endocrine therapy we use. I hope we don't need chemotherapy. It's not that I want to give chemotherapy, but at the moment we still use it, and the discussions we had 20 years ago was just the other way around. Do we need GnRH analog on top of chemotherapy? No, we discussed, do we need chemotherapy on top of GnRH analogs? And I think we should have done the PERK trial 20 years ago. This was a missed opportunity, in my opinion. This clearly phrased the question, GnRH versus chemotherapy with optimal in both arms was tamoxifen, but we didn't do that, and I've heard that there might be a trial coming up in the US answering that, and I think, I'm not sure if it's the right time, but if it's doable, let's do it.
Well, with that, I want to thank our audience for voting, and I want to thank our speakers, Drs. Loibl and Gnant, for a terrific set of presentations. Enjoy the rest of the conference.